Good morning and welcome. Thank you for joining us this morning. We're very pleased to have you here in this intimate roundtable update that we're going to have the pleasure of presenting you. We are Mintz Levin, an American law firm that is well known for its life sciences practice. We've been active in Israel for over 10 years now. We're very fortunate to have dozens of Israeli clients in this space. We are full service, so we cover everything from helping entrepreneurs figure out what they want to do, put together their patents, and put together a company through their M&A transactions, IPOs, you name it, and in between patents, regulatory work, employment, litigation if, God forbid, you need to deal with it, and basically mostly everything that a company of your nature would need during the life cycle of their product. I would like to thank Pitango for hosting us today. Our meeting room, we share offices with IATI, and we are IATI are also our partners in this event, and in a minute I'll invite Benny Zeevi, the co-chairman of IATI, to say a few words as well. So we would like to thank Pitango for hosting us here on a short notice, and IATI for partnering on this event. And without further ado, I would like to invite Benny, and then we'll introduce Susan, and we'll go straight to the presentation.
So my name is Benny Zeevi. I'm the co-chairman of the IATI, and also a managing partner of DFJ Tel Aviv Venture Partners. I'm happy to host Susan and Mintz Levin at our joint event. Susan is an old friend, and Mintz Levin, of course, of the life science industry in Israel, and she's a frequent visitor in Israel and gives a lot of talks and share her knowledge with us. The IATI, as you all know, is the umbrella organization of the high-tech and the life science industry in Israel. We have members from startup to multinational, to all incubator, venture capital, accelerator, basically, and all service provider, basically all the ecosystem of the high-tech in Israel. And we promote the high-tech industry in front of the government. We do a lot of meetings like that, small meetings with our partners, like Mintz Levin, and we share the knowledge with our members. So whoever is not a member is welcome to become a member of the IATI and enjoy those meetings. So without further ado, Susan, please.
Thank you.
So Susan is the managing partner of our DC office, a senior health law specialist, and a member of our executive committee, we call it policy committee in Mintz Levin. And she has over 30 years, or almost 30 years of experience.
About 30 years, yeah.
And
Yael makes me sound old. I'm senior and I have 30 years experience. I don't.
You're just right.
Well,
that's it.
experience.
Yes, exactly.
So I'll let you take the
Thank you. Thanks, Yael. It's great to be here, Benny. Thank you. I always enjoy coming to Israel, as I was saying to Benny, as well as to others at the mHealth conference yesterday. There's a real revived energy in Israel that we're feeling over a lot of the companies that are developing technologies in the mobile space, as well as many devices and other types of healthcare applications. So today I will provide an update on health reform, which has been in the news a lot. We can call it the Affordable Care Act, although lately it has taken on the name Obamacare, and I think it will forever be known as Obamacare now. And I will provide some updates about that. I'll probably also go off script a bit based on some of the comments and questions I was getting yesterday about other issues of concern to Israeli tech companies. So we have, what I'd like to touch on is we have the passage of the Affordable Care Act, which was not without controversy. I'll touch on the provisions directly applicable to the technology sector. In addition, Obamacare was really dubbed insurance reform. It got watered down during its passage for reasons that probably aren't that relevant anymore, and it really became insurance reform. And to many tech companies, when it became insurance reform, I think there was some lack of interest in what it would accomplish. But I actually view it as the opposite. The insurance reform that's created creates huge opportunities, additional responsibilities, but huge opportunities for the industry. Part of that is the cost containment measures and how some of the technologies that you all are working with can prosper under those measures, and how should you plan to commercialize and move forward with your technologies. Very briefly, health reform is something that's gone on in the US for a long time. Bill Clinton had a comprehensive bill. At the time, it was Hillary Clinton's claim to fame until she became Secretary of State. Obama was finally successful in passing it in 2010. As everyone knows, it went all the way up to the Supreme Court with some sense that it wouldn't go into effect. The biggest effective date was 2014, January 1, 2014. I say was because there has been delays in some key provisions, but a lot of impetus behind others that we'll talk about. And it really is not an overhaul of how drugs and devices are approved in the US. It really is health insurance reform, but as I said, it has a very significant impact on the sector, and one that I think you should all take into account as you develop and commercialize your products. So in terms of the basics, it covers, it mandates insurance coverage for most Americans. This is extremely relevant because an increased population for potential coverage means an increased population of potential users of your technology and your devices. Many of the new population to be covered will be healthy, but that doesn't mean that they're not going to be looking for various types of devices, wellness, apps. We could talk about, I'm sure you can think of on your own, the many different things that even healthy individuals will make use of with coverage. People that aren't covered through their employers will be covered through these state exchanges. That was the big announcement last week. It was part of what led to the budget crisis and the fact that at the moment I am governmentless with no end in sight. But on the same day that the US government shut down, the exchanges went live and people could start going online and looking to sign up for these exchanges and get health insurance. It also expanded the Medicaid program. Medicaid in the US is the program for low-income individuals. Again, as written, all low-income individuals have to be covered. States can change that, and I do want to pause for a minute. Many of you probably know, but I think it's worth repeating that in the US we have a federal government and we have 50 state governments. And the 50 state governments you're going to hear me talk about a few times today. They are people forget about them, they focus on our federal laws, but they are probably one of the biggest obstacles or can provide some of the biggest opportunities for your technologies and your markets. And it's something that you really do need to pay attention to and is often some of the biggest complications that we see with our clients trying to go live with their products and their devices. And insurers cannot deny coverage based on pre-existing conditions, which was a big thing in the US. If you were sick, it was very hard to get insurance. Imagine that. That no longer happens, and things have to be covered. Disease states have to be covered. They have to be covered in an uninterrupted fashion. So again, there's opportunities created. This potentially adds more burden and cost to our system, which is already an overburdened system, and that's why we'll talk about the need for cost containment as part of health reform, but it does present opportunities. So what does this mean for the device and the IT industry? You've got 48 million Americans that were without health insurance that as of last week are looking for coverage. It's estimated that about 32 million of those will become insured. Which results in estimates of $115 billion of new business over the next 10 years. What this also will mean is that the insurers and the government will increase emphasis on cost control. I think, again, let me pause. We'll talk about it in more detail, but it really will be no longer possible to bring a product to market that is, I think the term I used yesterday is a new and improved Tide. It cleans your clothes better than it used to. New and improved is really, in my opinion, not going to be what gets reimbursement and what is accepted by insurers and other payers to come to market, to the extent the product that you're talking about is a product that for which you want reimbursement versus some of the mobile apps and the like that we talked about yesterday. You really will have to be able to show greater quality and cost savings because otherwise the system, the expenses will continue to increase in a way that Obamacare specifically mandated could not occur. So the FDA, and I'll spend a few minutes on the FDA, and as I was saying to Benny, this is where my presentation had a change over the last week, which is why we were having trouble finding the most recent one. The FDA, which has been so quiet for so long, came out with 3 different sets of rules in the last 2 weeks, one of which, in fact, was announced as I was flying to Israel. So the ACA has little impact on the FDA. The Food and Drug Innovation Act of 2012 is really what's driving a lot of the change we see. It's just that when you marry the ACA and the FDA, it creates opportunities and uncertainties of how new products and new technologies need to be approved and how they'll prosper under health reform.
It's not clear why there's a connection between health insurance reform and Obamacare and a government agency that's in regulation. Where you're saying that you're specifically emphasizing that, but why would we expect that the FDA as a government agency would have changed much, even though the way of insuring people in the States is changing?
You shouldn't expect that. However, I think that because the timing was quite coincidental, we often get a lot of questions where there's a confusion created that somehow or another the changes occurring at the FDA were as a result of healthcare reform. And there is a sense in the US, and I touched on it yesterday, the head of CMS, the agency that oversees all of Medicare and Medicaid in the US, has come out recently, and this is quite a change because, as Philip said, CMS is an agency that's very separate than the FDA, although HHS in some ways covers both. And the head of CMS came out and specifically said for the first time in a very public presentation that the CMS and the FDA have to collaborate more. They have to join forces, they have to speak to one another and communicate, because what has been happening because of the FDA and things like the ACA or CMS being so separate is that you would have companies, and having spent enough time in Israel and speaking with companies in Israel, there would be a very linear approach to the process. You get patent protection, then you go to the FDA about your clinical trials. When you get approval, then you go to CMS and seek reimbursement, and you start talking to insurers. And I have said, and it was nice to hear CMS validate what I've been saying, which is that there needs to be a collaboration between CMS and the FDA, and that has to be driven by the innovators. They're not going to just tell you to collaborate. Where as soon as you start going for your FDA approval, you should start thinking about your reimbursement and start your dialogue with CMS about whether you can get paid for your technology. And the reason for that is that we have seen instances where you can get approved for a product, but CMS then says, but we can't reimburse for it in exactly that way. We want it described differently. Or we already have a code, it's referred to as a CPT code, that reimburses something similar, and we'd prefer to fit it into that based on the evidence of what illness you're treating or what technology you're advancing, but that's not how you submitted your applications to the FDA. So what you've been approved for and what you're being asked to be reimbursed for don't align, which creates a whole host of other issues around off-label use, which is really not, it's permitted, but it's complicated. So I think it's a worthwhile point simply because people often think that somehow or another one happens and then the next happens and it all sort of creates this nice whole, and it really doesn't. It's a real process that needs to be better integrated. And I think as a result of health reform, we're seeing more interest on the part of CMS, as well as the states, in understanding the FDA technologies and what they need to do to help bring innovative technologies to market.
No, I think that in advanced clinical trial, you have to build into the trial your cost effectiveness and comparative effect.
Exactly right.
And all those issues in your advanced clinical trial, otherwise you wouldn't get reimbursed.
You're absolutely right, Benny, and I think there's actually different organizations that are developing that I'll touch on later that could help you or require that you do exactly that. A lot of these technologies, when you go to CMS, you need to be able to talk about it's cheaper, it's more effective, it can reach a larger swath of the population in a more expeditious manner. I think that CMS is going to start looking for that more. So a few things have happened with the FDA, and we'll talk about that, then we can get into some of the provisions of health reform. And all of these, as I said, have come out literally over the last 2 weeks. So to date, the FDA has cleared roughly 100 mobile medical apps. Interestingly, some of the apps that they cleared, they now say they're not going to regulate, which creates another issue. But effective 2 weeks ago, the FDA came out and said that we understand that mobile apps, unless they fall under the traditional definition of a medical device, do not need to be regulated. Apps which aren't covered under the guidance, and we're still waiting to hear how they will be governed by the FDA rules, are apps for patient-specific analyses that a physician uses in clinical decision-making. So it's not the fun fact social media apps where you can track your heartbeat and the like. Rather, it's some of the apps that physicians will actually start to use to determine health conditions. There will be 500 million smartphone users using health apps. And by 2018, it's predicted that $3.4 billion users will have downloaded one or more medical app. What the FDA said is that they will only regulate those apps that are an extension of the device by connecting to that device for transmitting information. So one of the examples that's being used very publicly here is the ability to upload radiological images, x-rays and the like. You download them, you can see the pictures on the device. Or if it transforms the device basically into a medical device. So I talked about devices that can perform EKGs. There's devices that can do blood glucose monitoring and the like, so you can test your own blood sugar using your smartphone. They will be regulated.
So the company that won the competition yesterday, Mobile OCT, that they have a device that hooks onto the iPhone, to your smartphone, and then can take a picture of your skin condition. So that would need to be regulated because that's an extension of the device? Yeah,
although I would guess that it goes beyond that. I think it's in the category that they haven't announced yet, which is it would be device used for clinical decision making, i.e. whether you need to be treated for cervical cancer. So I think that the reason that those have been carved out is that they may be subject to greater regulation. I mean, none of this is, I don't think, going to be investigated. I think it's all going to be 510K or whatever, but I don't think it's going to fall into just being listed or registered or labeled or reported. I think that a device like mobile OCT is being used to actually diagnose cancer, whereas an app like MediSafe, I don't think would be regulated at all. And there was Zoetics may be regulated more as a medical device because it downloads all the patient information. So I think, one of the things, these regulations, everyone was applauding the fact that the FDA gave a lot more information than they usually do in these regs. They were, I think, 43 pages instead of 29 or something, which is what the proposed rules were, and people were making a big deal out of that. But there's still a lot of information that we need to understand about the specifics of a device and how that device, if it's falling within this regulation, will need to be governed.
Given that the smartphone world changes every day, okay, is the FDA going to be able to handle,
what they would say, or what I would say?
Yeah, well,
what I would say is no. I mean, it's an overburdened agency. We have a government that just shut down. We have a Congress that's saying they're not going to increase the debt ceiling. We have other competing needs. The FDA needs to be, in some ways, completely overhauled or expanded. It cannot keep up with what it needs to regulate. I think this is a great first step, but I think that, as you said, technology is changing every day. So what they say today, next year, someone may have come up with something that they didn't know how to deal with. And quite honestly, this is a double-edged sword. The industry was very pleased to see that these devices aren't being regulated. At the same time, I think from an investor perspective, and I would defer to people like Benny, from an investor perspective, I'm not sure you want something that doesn't require, is it sexier, is it more is it a better investment if it requires FDA approval versus not having that stamp of approval, because then it can be sold anywhere? So I think there's a lot that remains to be seen as to, how these regulations are adopted and the fallout from them.
And on top of the FDA, the FCC is also regulating the apps.
Yes.
And the FCC, which is, communication authority, actually regulates the apps, and actually they took off the market like 4 apps that claim that they can treat acne, for example, with the light of the phone. So they took them off the...
Well, I was going to say, this is...
FCC, not FDA.
No, that's exactly right. And so this is where I'm happy to go off script for a few minutes and talk about other regulations. It's the FTC, the FCC. The FCC can regulate some of these apps depending on the frequencies with how they transmit. The FTC is regulating them, pulling things off the market for claims that are unwarranted. There are, even if you don't need FDA approval, there's still the HIPAA privacy and security overlay. Are you downloading patient identifiable information? In addition, I would caution that everyone says, well, even if we're downloading it, we're not using it. That's not what we want to do with our device. Well, if someone comes to you and says, I'll give you $10 million if you can now take all the data that you're getting and you can aggregate it in a way that we can sell it, because that's a big thing. Data analytics is a huge growth area. You're going to say yes. And I'll tell you, we've done a number of due diligence projects recently where the company cannot sell that data because they didn't do the right thing up front on privacy and security. And getting your policies and procedures in place for privacy and security is not that expensive. Everyone's worried about the US lawyers. We're expensive. We are. Getting those policies and procedures in place is not that expensive. But I caution everyone, don't say you're not going to use your data. We're not going to use it. We don't need it. People just come onto our site. It's,
Actually, many companies are actually claiming that these data, they are going to use it, like big data analysis and etc. So they are gathering a lot of data. So.
Right.
So that's the other side of it.
The other side of it is please be HIPAA compliant, because we're finding too many times that
sell it very easily.
No, it's a big, if you had asked me 10 years ago, it shows that, don't go to Las Vegas with me. If you had asked me 10 years ago if I thought HIPAA would take on the authority it has taken on in the US, I'd say no. I would have said no.
And should have read Gartner.
Yeah, I should have, clearly.
Gartner predicted all along that HIPAA was going to, in essence, HIPAA's become a worldwide standard, by the way.
It has.
Okay? We tell all our Israeli clients, even if you don't sell in the States, become HIPAA compliant, because you need the checklist. You want to be able to show that you're covering the data security.
It's definitely the gold standard.
So, that's like become the de facto standard.
But part of the reason is, given my advanced age that Yael pointed out 10 years ago, I'm not sure I could have predicted that technology would get to the point that it is, where the type of data could be gathered and analyzed and manipulated, and I mean manipulated in a good way, to figure out trends in disease states, trends in drug use, all the things that we see it being used for.
Well, from that perspective, I think hats off to a government agency that could predict that in a way that's not very typical for...
No, that's exactly right. And I remember when Bush came into office, he thought about doing away with overturning the HIPAA rules, and he didn't. He left them in place, which was surprising and has resulted in a new standard. And I will caution, this is one of my state law cautions, HIPAA is one of the few laws in the US, there are others, that we referred to it as preempted, which means that when the federal HIPAA law passed, it did not preempt or take over the 50 state HIPAA laws that are more restrictive. So if you're operating in a state that has a privacy law that is more restrictive than the federal law, you must comply with the requirements of the state law. And it has created quite a regulatory nightmare, because if you're operating in 50 states, who operates in one state? If you're operating in 50 states or 10 states or however many, you must comply with the state law if it's more restrictive.
Which is considered the most rigid?
For HIPAA,
Yeah.
probably California, but there's a lot of them. There's some where it's surprising. California, Florida, some of the big states that you'd think about.
East Coast?
Probably New York. In addition, there's another area where that applies to, which I think is just another thing to be aware of, is the whole topic of telemedicine. A lot of the apps and devices we're seeing are to be used remotely and to allow for a better way of seeing your physician or not having to go to the physician. It's one of the devices we saw yesterday, was a device that would allow for the remote analysis of a throat infection or an ear infection. Telemedicine laws, there's no federal telemedicine law in the US. It's all governed by 50 state laws, and they are all over the map. We actually do a lot of work in the area, and they are all over the map, and every state needs to be independently and individually lobbied to decide whether or not they'll allow these services to be delivered remotely. So again, many, many things to be aware of that are constantly changing.
The physician needs a different license in each state.
Yes, yes, that's right.
So you cannot actually consult if you're in California or someone in Boston.
No.
You need a
No, there were
physician license in order to consult.
There have been legal cases about that also.
Yeah.
For sure.
No, you do need, I do a lot of work in the pharmacy benefit space, companies that manage drug benefits in the US. And we often come across this there as well. I mean, we have it down to a science, but a pharmacy that's a mail order pharmacy, you have to be licensed in 50 states. So you have to send out applications to 50 states. Same thing if you want to practice medicine. You usually, now these days, you choose a handful of states. So if we're talking about Washington, D.C., I have a client building a bunch of urgent care centers, and he's getting licensed in Maryland, Virginia, Washington, D.C., and I think he's going to extend to West Virginia and probably up to Pennsylvania. So it's a very complex regulatory structure that I encourage folks to seek guidance and to understand, because it goes beyond sort of what is the most publicly expressed as the applicable laws.
And at the FCC layer about the usage of internet and where you do business,
Yes.
regardless of the, which start to become more. I think there's more clarity on that recently.
Yes, as well. So as I was flying to Israel, there was more FDA guidance issued, and this was for higher risk devices. Again, just want to touch on it.
Which is?
It's unclear to me. They're investigational. High risk devices, I would say, are implantables with electric shock, new ways of pacemakers, new implantable devices. And they've issued new guidance regarding investigational device exemptions. Again, I put this slide in for folks to be aware that this is out there. I can't tell you that I've really digested them. You need to provide information on the condition the device will address, the anticipated benefits of the device. You have to provide information about previous studies of a device and the need for new trials to show, the old device pacemakers that run on batteries, let's say. The batteries die, people's pacemaker, so now someone comes up with a new pacemaker. Maybe there's a new way of powering it or a new way of tracking it. Thierry was talking about in Europe, they have these new ways of tracking pacemakers, what the benefits and the risks would be. So again, just another area where the FDA is starting to make pronouncements, and I encourage folks, and I too need to learn more about this area and the regulations in this area. So beyond the FDA, we do have provisions in the ACA that are applicable to biopharma and medical devices. There's a regulatory pathway that was put in the law for the approval of biosimilars. The Physician Payment Sunshine Act, another one that I don't see as having real teeth or traction, but it's getting a lot of play in the US, which is the need for very specific public disclosure of financial arrangements between providers and biopharma or medical device companies that will allow a patient as well as others to see if the physician's medical judgment is being impaired by the financial returns that they'll be receiving from using the product. Huge database being created around it. It created a Cures Acceleration Network, I think a type of incubator on steroids to look for new innovative technologies. NIH has a new Center for Advancing Translational Sciences. And there's new taxes. There's the medical device tax and the branded prescription drug fee. Very controversial in the US, and these dollars are quite significant. Just another obstacle to coming to market in the US. The medical device tax is fascinating. The medical device tax was actually, if you followed, which hopefully you didn't, but if you followed the big debate before the government shut down, the Republican head of the House, John Boehner, he had two things he wanted in order to approve the budget. One was that Obamacare be delayed. But the other thing, out of everything he could have asked for, was the repeal of the medical device tax. It's gotten real play in the US. As you can see, it is not an insignificant tax. It's 2.3% of the sales price. Many, many dollars expected to be raised over the next decade, but again, the final chapter hasn't been written. There's a real sense that this had a chilling effect on bringing new technologies to market. I think it was much too soon to tell that, but I would expect that the medical device tax will be repealed. We're not seeing the same pushback on the branded prescription drug fee. So the ACA and health IT, I use this medical loss ratio calculation as an example. So the American Recovery and Reinvestment Act is where Obama tried to re-stimulate the US economy by putting dollars out there that would stimulate investment in businesses. But in addition, the ACA has important provisions for health IT. And one of the important provisions is this medical loss ratio. The medical loss ratio, in essence, requires that 85 cents of every dollar be spent for the provision of health care by an insurer. If they don't spend 85 cents of every dollar, they have to refund part of the premium to the customer, saying you paid too much for health care and we spent too little on it. What has happened now is that you can see that on the top line it's medical benefits paid plus quality improvement. Medical benefits paid, there's a bit of a tension being created there because, as I spoke about earlier and I'm going to speak about in a few minutes, there's a real push to control healthcare spending in the US. There's a real push to come up with quality programs that decrease healthcare costs, make it less expensive to deliver healthcare services. So at a time that you're saying more dollars have to be spent on healthcare, now one of the logical explanations is just offer more benefits, but at the same time that you're saying spend more on healthcare, you're saying things have to cost less. So one of the things that's going on that is creating a real incentive in the industry, and I can't even tell you how many questions I've gotten about what a quality improvement cost is over the last several months, is that if you have a product that improves the quality or the delivery of care, and it's a relatively broad definition, increase the likelihood of desired healthcare outcomes, health quality, directed toward individual enrollees, meaning you can target individuals for care management. If they have several chronic health conditions, you have a way to target them and get them better care that treat them more holistically. That will count on the top line, which is very important, because that's where we're starting to see a lot of innovation, and that's where we're starting to see a lot of expenditure. And there are companies that we're advising that do just that. They can go to the insurers, they can go to the providers, they can go to the health systems and say, we can do it better, and the dollars we spend on making it better will count positively toward your MLR.
But you just said that new and improved tide won't count.
New and improved tide won't count.
So again, this is this a subjective, improvement quality indicator? I mean, those things are not always that easy to.
It's somewhat subjective. I think in part it's somewhat subjective because it is new. But I see algorithms and other methods of, for example, patient outreach. Telling patients that there is a program that can result in better outcomes for their chronic care conditions. What you pay the company that does the patient outreach would count as a quality improvement cost. So it's a service concept as well as a product concept. And actually where we're seeing a lot of the growth and inquiries on the quality improvement costs is in the service concept, just as much if not more than the product concept. What has not happened in the US, notwithstanding the fact that we have HMOs and this concept of managed care, is that care is not carefully managed. And there are many, we'll talk about some other innovation programs, some of which are more successful than others, to manage care better in the US. And this is providing a big incentive.
So even something like we can reduce hospitalizations, okay? We can
huge.
We can reduce readmissions. I mean, anything along those lines.
Correct. It would improve health quality, the likelihood of desired health outcomes. Absolutely. And we're seeing companies build themselves quite successfully around the ability to do that, whether through patient outreach, whether through algorithms and IT programs and the like. It really is an emerging area.
How long you can count as an improvement
Excuse me?
if you are selling software? You having to improve the quality of care. For how long it can count as improvement?
As long as you're paying for it. So if this measurement is undertaken by the insurer. So if the insurer enters into a 10-year contract with you for whatever service you're selling to improve quality of care, each of those 10 years.
After a couple of years, it becomes a standard. Yeah, but it still improves.
But it still improves.
For a baseline.
Yes. Yeah, you improve the medical care.
Well,
Remember, this is not the actual delivery. This is just the numbers, how the numbers play.
It's not
Yeah.
real work.
Right. They just want you to invest in better care. Then they can put it on the top line. That's it.
Yeah, but
At some point.
I just understand.
Yeah.
Understand the logic.
No, and quality leads to quality. I mean, these are all new laws that will evolve over time, and the reports will evolve over time, because people figure out ways to get around them and to test them and to push the limits of them.
Which agency basically checks the MLR?
CMS, HHS.
Do they actually do it?
Yeah, the reporting is quite detailed and quite cumbersome and laborious. The reports require incredible detail.
Have you ever heard of a person that got money back?
Yeah, I have a friend that got a check.
So it works.
It works.
This would never work in Israel.
They got a check in the mail. Yeah, but you don't have the same issue in Israel. So I'll tell you that part of the genesis of this.
They do it themselves.
Right. I mean, it's.
Today we've been paying insurance,
Yeah.
health tax. We're getting less and paying more. So I don't understand why.
Mamash lo nachon. We're getting. Have you compared yourself to the Americans or the Canadians?
You're getting more.
I understand that lately we cannot compare ourselves, that they're doing worse than we are.
I mean,
But we are paying a lot.
You pay.
my friends in Switzerland pay a lot more.
With all, I mean, you can't imagine how much we pay for health insurance in the U.S. I pay the full freight for my health insurance for me and my kids.
Right.
No, it's said it, but okay. Maybe that's a separate discussion.
Yeah.
10:31.
No, I mean, the point is that it is driving behavior, and it's driving behavior in a capitalist market like the U.S., where there is a sense that too much money, as is true in many of the industries in the U.S., was going to pay for things that didn't relate to the core function of the company. So what other opportunities are created for health IT? Systems that are needed to implement the healthcare exchanges. So right now, both you needed systems to be able to get in to learn about the health exchanges, allow folks to analyze different insurance rates, purchase the insurance. There's requirements report about quality indicator reporting around the health exchanges. Again, as we talked about, the ability to track and report quality of care measures. This is important. For example, you're going to CMS. You want to prove that your product is better than the old product. You need technology to track and report the quality measures. The problem is you need to be able to sell providers on cost savings from the systems, because a lot of this, the information the providers have to generate. You also need to connect patients to their providers. There was a recent survey, 41% of Americans would consider switching providers to get access to their EHR online. This is a big thing in the US right now. You want to be able to push a button. I have an app that sits on my phone, and I can click it and get my medical record from my provider. So,
You guys got to move to Israel, that's all.
well, no, I finally have it in the US. It just took me a little longer than you.
We've had it for
Yeah, I finally get my lab tests online. You guys have had it for a lot longer than we have. But what else is going on? There's general cost controls that are bumping up against this desire for innovation. Pay for performance for providers. Providers are now being told, if you have better outcomes, we'll pay you. If you don't do that well, we're going to take some money away from you. There's increased emphasis on areas where savings can be achieved. Prevention. We saw a number of wellness apps yesterday, or in the various meetings we had with some of the companies that were presenting. Wellness and prevention is a big thing in the US. In fact, there's a bunch of preventative care that insurers must provide for free under health reform. They can no longer charge for it because they don't want any barriers to receiving those preventative services. Incentives for cures versus long-term symptom management and disease management programs. These are areas where, to many of you, it may seem so basic to be part of a health system. These are areas where the US health system has failed. We just have not emphasized them or spent a lot of time or money on them, which is why an overwhelming percentage of our healthcare dollars are spent during the last 6 months of someone's life. The use of generics. It will continually drive insurers to incentives using generic drugs. I have my own opinions on that. I think that there are plenty of drugs that aren't generics that are becoming more cost effective. But the bottom line is it's going to all be about pricing. If you have therapeutically interchangeable drugs, you absolutely are going to be driven toward the most cost effective one of those products. There are concerns about safety and efficacy of generics, imported generics. We know, for example, the whole Lipitor, Ranbaxy story. Everyone was chomping at the bit for Lipitor to come off patent. It does. Everyone should be driven toward the generics. There were investigations of whether Pfizer was trying to keep folks loyal to Lipitor. But in the meantime, the biggest manufacturer of the generic version of Lipitor had very significant issues. What else are we seeing? CMS established its own system to try to motivate innovation. So one of the biggest things that's happening in our system is we're moving away from fee-for-service, volume-based payments. If you do 10 procedures, you get paid for 10 procedures, to a value-based payment. Could you do one procedure that's better than the sum of the 10, in which case you'll get paid more for that one than for the 10. And there was an innovation center set up within CMS to design, test, and evaluate pilot programs that could improve or maintain quality while reducing costs. The program in and of itself is innovative. It's $10 billion over 10 years with unprecedented authority to implement these pilots nationally without going back to Congress and saying we want $1 billion for a new disease management program. They can implement the programs and put them in place. Examples, ACOs, bundled payments, value-based purchasing, national clinical registries. Every state is involved. There's private partners. It is a huge initiative that has had incredible outreach. We actually just hired a gentleman who was in CMMI His network is incredible, the number of organizations that he worked with developing these types of programs. How they're going to be funded, whether a program that you're thinking of would be able to receive approval under this, I don't know the answer to that. I think it's a little unclear at the moment, at least to me, what the process is, but there is a lot of money available. Accountable care organizations. Accountable care organizations are intended to incentivize quality metrics and cost savings. They are basically an integrated delivery system that is approved by CMS. It is intended to be based on evidence-based medicine, patient engagement. There are, you're supposed to basically integrate and coordinate care among a whole host of specialties. You have to submit an application with detailed information on your network, as well as the type of healthcare services that you're looking to deliver. They have a very significant need for EHR systems. They have to coordinate the providers, they have to coordinate the payments, and the crux of the ACO program is that you will receive a portion of the savings that you realize by coordinating care and from the government. And so you absolutely need technology to engage in case management, coordinate providers, calculate the savings, demonstrate the savings to the government agency, to CMS in essence, in order for these programs to be successful and for you to receive a payment.
Does it pay for us to start a dialogue with ACOs? I mean, there's a whole bunch of them around now. I mean, they have the power to buy and...
Yes.
Yeah.
They need the technologies.
Right, okay. So
we're actually doing that for companies.
We have a bunch of ACOs that we're working with, and they're the real deal. Whether they're the PHOs of 2013 and they don't last forever, I think remains to be seen, but for the moment, they're very real. And yes, I think dialogues with them, they have significant buying power, and they're looking for innovative technologies to make their programs work.
Are there different stakeholders that really set the shots within a particular ACO? Is it the hospitals that usually are the dominant?
Depends who you ask. I mean, the hospitals are very dominant. The hospitals wanted to be dominant in the ACOs, and I think they are coming out as the dominant player. There are some health plans that are quite dominant in establishing ACOs. Some provider groups, but I'd say mainly hospitals and health plans.
But there are many small groups of doctors and physicians that are establishing ACO by themselves, hundreds of them already.
Yeah, or they're joining together to become more powerful within an existing ACO. I mean, there's certainly... I agree with that.
Like five physicians.
How can they be an ACO?
They can't be an ACO if there's a broader network. They're typically going into existing ACOs.
How can the whole concept is that you provide healthcare in an integrated fashion, so urgent care and home.
I'm saying several small groups, like 5 physicians from various subjects and various programs, will get together to provide more efficient care.
They're certainly looking, the biggest concern with the individual providers is there's a real fear that they will lose their place in the market because of the insurers and the health systems. And we are seeing provider groups coming together and, for example, starting their own health insurance plan, their own Medicare Advantage plans, trying to figure out if they can start ACOs. I had a client that was going to do an ACO, but what they typically are doing, what my client did, is you seek another partner. You may want to be the leader of the charge, but you seek another partner because you have to develop a network that's robust enough and has enough of the players in it to function in the ACO market. But there's a huge need for innovative services and technology in these ACOs in order to achieve, track, and receive the savings.
But many of the physicians in the States are actually now moving back to the hospitals.
That's exactly right.
To large systems that don't operate anymore
That's
on
the
themselves.
motivation, yeah.
We're
So
seeing,
the
yeah.
expenses, the insurance,
The EHR.
regulations, the EHR and everything. So they're moving back to the hospital system, any provider.
Yeah, it's another time where my reference as being a senior attorney, I mean, you see the trends, and it's not as if it's this trend where everything changes. It sort of comes around and recycles and recycles. And there was a time, and I think, Benny, was it the 80s, the late 80s, early 90s? where physicians were affiliating with hospitals. Then they got away from that because there was a sense that we were heading toward a system of less acute care, and so they should be independent. Now they're going back and forming these integrated systems. There's companies that we're looking at, that we have clients looking to invest in or purchase, that we're evaluating, that consist of provider groups, health plans, potentially a hospital system, an IT company. We've seen a couple with regional PBMs, pharmacy benefit managers, so that they can provide in a very comprehensive fashion all the care, all the services that are required. And I think, the day of the independent physician sitting in his office practicing alone, writing his charts out and getting an insurance contract is really past.
So most of them will now become attached either to hospital organizations or these ACOs, is that what you're saying?
We also are seeing large IPAs, independent practice associations, develop.
How's that different from a managed practice? I have a friend who lives in San Diego, and he's part of a large managed practice.
It's probably a type of
50 physicians.
Yeah, it's a type of independent practice, an IPA, where you basically bring a bunch of physicians together under some loose corporate umbrella that manages them, takes care of all their expenses, all their buying, all their supplies, all their IT, and also goes to the insurers and negotiates on the group's behalf. And because you now have a network of 50 doctors, let's say, versus 10, the insurers are often much more interested in you because you cover a wider swath. And certainly with the government-funded health programs, there are minimum access requirements that have to be met by the plan.
So the incentive for setting up an ACO is, as you said, to save money? Is that the idea? To provide these integrated service providers that
Yes, it's another way of integrating care. I mean, the government's motive is that if you motivate folks to practice together and bring to bear incentives to save money and provide more comprehensive care in a less acute setting, it's good for the health system. And the only way to do that is to incentivize folks to practice together versus as independent pieces.
Just for example, I think that the early motivation for the hospitals was the penalty for readmission that was
correct.
So the hospital has a motivation to incentivize the community to keep the patient healthy enough so it won't come back.
Yeah, and how do you do that? You do that by outreach into the community. And how do you do that? By having community-based physicians that integrate the health records. I mean, it's not, it's one of the things Zoetics was saying yesterday. You need to be able to bring all the healthcare information together in order to treat the patient in a way that's comprehensive and probably avoids medical errors, avoids readmissions and the like. Other federal initiatives to address costs, just briefly. There's an independent payment advisory board that's been established that is to look at and try to control Medicare spending. If Medicare spending exceeds established targets, they have to submit recommendations to Congress to reduce spending. This could influence other payers. Any Medicare trend always influences private payers in the U.S. This is politically contentious. It obviously is a bit of a Big Brother is watching, which isn't received very well in certain political sectors in the U.S. There's also, it established the Patient-Centered Outcomes Research Institute. I refer to this as the comparative effectiveness studies that are mandated under health reform. They can't mandate coverage, reimbursement, or policy, but they can analyze, and I find it fascinating, in a very scientific, detailed fashion, various healthcare initiatives to treat similar conditions, and over time determine what is the most cost-effective method of treatment. One of the first examples that was being given is that there are studies out there that says intense physical therapy can be just as effective as disc replacement for treating certain degenerative spinal diseases. And physical therapy has got to be 1/100th of what it may cost to get a disc replacement. So that sort of became one of the poster trials a couple of years ago. A lot of work to be done here, but again, it's another way that innovation is going to become important, not just to say we can do it better, we can make people walk better because the spinal implant we're using is made out of titanium instead of plastic. I understand that titanium was used many years ago, versus saying we have a way to treat the patient in a more cost-effective manner that will achieve the same outcome without being quite as invasive or expensive. So as we get to the end, what do I want to leave you with? Demonstrating value. Drug and device and IT companies have to demonstrate that your products will provide savings and improve quality. I think that using terms like value and quality are just becoming key factors as whether you're going to investors, whether you're going to the FDA, whether you're going for reimbursement, whatever the case may be. Is it less expensive or more efficacious? Can it be used on an outpatient basis versus inpatient? As Yael said, there are actually penalties now for readmission. Under health reform, there were talks about medical home. They're trying to treat people in less and less invasive or intense acute settings. You should be able to demonstrate things that demonstrate cost savings from reduced hospital admissions. For ACOs, drugs paid through Part D are not included in costs for the ACO. So you need to be able to show that you're saving money. If you're providing drugs for people pursuant to the outpatient prescription drug program for the elderly in the US, that doesn't count. Person goes inpatient, they have to receive their drugs inpatient, your costs just went up. So you can see that there are trends and initiatives. Demonstrating value is very important. Health IT companies, you also need to demonstrate value to providers, health systems, and insurers, because the reality is that your product is not a product for which you are seeking reimbursement necessarily directly from CMS. You want someone to buy your product to be part of what they're being reimbursed for, part of their overhead, part of the DRG, for example, for hospitals. Can they coordinate care between providers in a system? The US healthcare market has been so fragmented that one of the big initiatives is can various computer systems talk to one another? So we have hundreds of billing systems. Do you have a technology that can make them talk to one another? Can they provide decision support for providers? Do they make it easier for the provider to diagnose an illness or a condition? Enhance patient satisfaction. We heard from the insurers yesterday about patient satisfaction and patient care. Part of that is the altruistic message. Part of it really is that there is such competition for enrollees in health plans in the US that if you're not satisfied with your health plan, at the end of every year, we're going into it right now in the US, it's way too easy to switch coverage. More difficult on the commercial side if you get it through your employer, but for the elderly population, Medicare and Part D programs, you can switch every year if you want. It's entirely up to you. And technologies to aggregate and analyze outcomes data. We talked about the importance of data to improving and demonstrating improved quality. So what should you be thinking?
The HHS actually released all the data for general use to analyze that.
Yes, HHS is becoming much more open. They want collaborations. They're talking about many more. It's a great point, Benny. They're talking about collaborating much more closely with the private sector. They understand that they need to be more open and understand the data, because otherwise they can't do what they have been charged with doing, which is to reduce costs and improve quality. So generating profitable products require more than R&D spending, clinical design, and knowledge of the FDA process. New hurdles to profitability, getting payers and government to use the product. As I said, it has to start at the beginning. Even CMS is saying that they want to see folks coming to them when they're submitting their tests and their test design to the FDA and say, is this something that you pay for? How do you want us to design it? Because having a wonderful product that's been approved, if folks aren't going to pay for it in the US, it obviously limits your market. So there was a recent E&Y study that identified areas for companies to address for evidence-based medicine and reimbursement. Discontinue product candidates that may not exceed current standards of care. It's sort of like when a public company announces its earnings. If it meets earnings expectations, the stock goes down. It has to exceed earnings expectations to get any bump in the stock. It's sort of the same thing. Saying that you can do the same thing isn't really what the US market is looking for. Saying that you can do something different or you can do it better, or different is more cost effective and better, is really where it's at. Add payer reimbursement experts to the company, your management team, your clinical development teams, your board of directors. And report also shows that most companies aren't using and are not planning to use approaches related to payers and reimbursement. It really is not a plug for legal services. A lot of this work is done by consultants as well as lawyers, but I really can't stress it enough. We're seeing too many products and technologies that fail because there just is not an easy path to reimbursement, or the path of least resistance was taken and the company tried to fit it into an existing reimbursement structure in the US that could not support the technological advances and the costs involved in bringing that product to market. And therefore it just, by the time they then tried to get to CMS and get CMS to change the reimbursement, it was in certain instances too late. So key considerations: understand how your product will be reimbursed. Are there other products already on the market? Look at them. How is your product different? Why would an insurer want to pay for your product versus the other product? How can it generate savings? Adherence to a drug regime to avoid readmissions, one of the products we saw yesterday. Reduce hospital admissions or be accomplished in an outpatient visit. Side effects. Know what your side effects are. Is that going to increase the cost? That's happening with a lot of, for example, cancer treatments. It may be a better cancer treatment, but are you then following up with other treatments for the side effects? Incorporate those concerns in your product development. Show improvement. Address reimbursement and payment issues. Thank you for your time. And I like the collaborative, interactive nature. If there are other questions, happy to entertain them.
We have to digest it.
Yeah, that's right. Yeah.
It didn't all make perfect sense.
Yeah, you raised a lot of very important points, and thanks. That's some important emphases here, especially the one about CMS and FDA, and because you're right, we were always working in a linear fashion, okay, until now. We always said, okay, we'll go get the FDA, and then, near the end of that, I'll make sure I got my reimbursement code. I know I saw this reimbursement code. It's like it's close to the one that, I'm going to handle, so it must be okay.
It's a point that it's so important to make. Yeah.
Right.
But I see it in my practice all the time. I should be clear, I am not an FDA lawyer. I understand the FDA process because it's important to my practice, but I come in more after the FDA approval and either deal with the strategy for reimbursements and payers, the strategy of how to present to an insurer, having spent time in-house, and then the negotiation of the contracts for those products with payers and others. And so, very often, and I saw it a lot in Israel, folks are like, well, it's way too early for you. But I can't stress enough that with these new technologies and what's going on in the US market, and all kidding aside, when you see things like the US government shutting down and the cost pressure that's coming to bear, you will be so much more successful if you bring to market something that you very early on started discussing those issues.
As an Israeli who lived in the United States and came back a few years, I must say, and we are focusing on that segment for the last 8 years, I think. And Susan came here 5 years ago, 4 years ago.
Well, 2006, I think, was my first time.
Right, but I'm talking about your first Obamacare presentations here. I think it was 4 years ago.
Yes.
And it seemed completely ambitious, and how would the intentions be translated into actionable activities and targets for the industry, really. And I must say that this huge warship is starting to turn. They are fighting, but the market there is changing significantly. The way that they are going to do business in healthcare is going to be significantly different than what we've been used to.
What stage of the company, of the startup, you recommend to start really considering the CMS and in parallel to the FDA?
I think this isn't, it's going to sound like a non-answer, but I'm going to say it depends. So for example, the first thing, obviously, although this is an interesting discussion we were having yesterday as well, is to protect your IP. Although, depending on how you protect your IP, you don't want to miss the market and have the technologies get ahead of you. In some ways, it depends on your product. If your product is an implantable device, a new retina, a new way of delivering some sort of medication, where CMS, a new way of heart monitoring, for example, where CMS reimbursement is critical for you to be able to, as soon as your FDA approval comes in, and as you know it's going to come in, to be able to go to insurers and others and say, we're ready to go to market, we're better, pay for us. Then I think it's critical to start very early. As you're starting with the FDA, it's not that you spend hours and hours with CMS, but you go to CMS and say, listen, we're just starting our FDA process. This is what we're thinking about. Have anyone else come to you with similar products? How would you view this? If you're health IT, where you are looking to fit under a DRG, an existing reimbursement scheme for a health system or a payer, so that's your market, not direct reimbursement, then it's not as critical. Then I would think I would be doing my legwork, finding out what the insurers want. What are the hospitals currently using? How would they view your product if it was presented in XYZ fashion? So it depends. And very often what I'm talking about is just a few hours meeting, not this very intense year-long project as the FDA is. But just to make sure that you're structuring it right and going to your target audience.
Because of the difficulties in the United States market, our advice often to Israeli companies is start in Europe, get your CE mark, start getting traction, start getting revenues in Europe, okay, polish off your product and then start the long, arduous process with the FDA, okay? In your experience, does that have much influence on the FDA if you come in with, European experience and CE mark, or they say, not invented here and we don't really care?
Hard for me to say because I don't do enough work in front of the FDA. I think it's got to have some bearing on it because some of those studies are accepted for purposes of the FDA study, so I don't think it's without import. I think it depends on the technology because we're seeing a lot of things come to the US, especially in the IT area, because if you take the time to try to go elsewhere and then come to the US, you've missed your market. And so there's technology companies in Israel that we've seen that we've brought to market in the US in very, very early stages. And they've been quite successful, including relatively early exit strategies, because part of the problem with a lot of what we're talking about is we could be talking about something different a year from now. I mean, that's just how quickly some of this is moving. So for the FDA tests, we are seeing some of the tests be done overseas. They're accepted. I think, again, I wouldn't want to opine on how the FDA views it, but I'd also say that it once again, it just depends on the product.
It seems that the market needs are going to be significantly different because the structure of the health system is going to define so much of the needs in the coming years.
Well, the biggest area right now, I would say, is technology. The U.S. has been pretty good at finding, either developing in the U.S. or finding from elsewhere, good drugs and good medical devices to actually treat the illness. We don't do it in an integrated fashion. It's very expensive, but we're pretty good at it. What we're really bad at is the technology. And we're behind, in my opinion, in how we deliver care and how we use the information to analyze the quality of the care and the trends that are developing. And there's also trends developing in the US where technology is going to be critical. Obesity. One of the hugest health issues that we have in the US now is obesity. How do you treat it?
Maccabi's coming out with another app with a smartphone.
Right. I mean,
It's supposed to actually not only count calories, but deal with your psychological state of mind and ask you questions when you start to eat, because it turns out that your state of mind often influences how much you eat, of course. So
very passive. I mean, it requires the individual to decide that they're going to log on to their app, and
But it's a worldwide problem. Well,
it is a worldwide problem, right? And so how do you treat it? Because it isn't as simple as saying we're going to bring someone in and tell them to lock the refrigerator at certain intervals of the day. So I personally, I believe the technology has to play a role in that. There'll be drugs that'll play a role in it, but there's got to be technology. So that's where I see a lot of the innovation occurring, but it's also the thing that changes the most rapidly. So it's hard to say, go to Europe, come to the US, be slow, be deliberate about it, because a year or two from now we could be talking about some other sort of, we think it's going to be the smartphone. I don't know if it's going to be a smartphone.
I was referring more to medical devices, but you're right.
Yes.
Healthcare IT, your answer is right.
Yeah, for medical devices, it's much more processed.
But even what I think the integrated IT into the medical devices is a growing trend. So
Yeah.
that and the interaction between the medical devices and some form of communication with either with your cell phone or with the system in some way, and again would change the way that care is delivered. The question is when.
Well, this is new that the FDA is now going to regulate mobile apps also. This is
Well, it's new that they're telling us what they're going to regulate.
right. Rumors before, right?
Yeah.
But actually, not talking about it around the table is the big problem. Is I'm doing medical devices for 20 years as a lawyer. I used to have like 3-4 new companies a year. I think in the past 3-4 years, if I see one a year, it's a lot. With this becoming now an FCC problem, an FDA problem, now a CMS problem, companies don't survive getting all the expertise they need and funding in order to get that far. So if it's going to change from this year to next year, what I did this year is money that I threw out because it's not already relevant next year. Companies are not surviving this anymore. Forget getting to market. They barely get to the CNS stage. We represent, for example, Mazor. I mean, yesterday my partner told me, they're up to $1.5 billion shekel value. Now I remember them shutting down in 2005 almost, in 2006, and today it's big hype. These companies, from Israel at least, trying to get to the States where it's a big market, are really having a funding problem. I mean, entrepreneurs don't want to go there anymore because they know they get stuck between going to the FDA. Every time they go to the FDA, so they don't pay you, but they pay a partner that does the FDA. They don't get there anymore. So with everything changing all the time, it's just getting more and more difficult for the technology to get from here to the States.
I think it's a fluctuation point, and we were anticipating that when the healthcare reform was introduced, and we will have at least several more years before there will be full clarity on how the business model is going to work, and so there's a challenge to develop new products.
The States wants to get technology, but they put every obstacle in the world.
That's changing. I think it's changing.
Let's take it down.
It's a lot of infrastructure.
Well, now that you don't have a government, you don't have anything to blame.
Yeah, exactly. But it's changing. Yeah. No, yeah, we're waiting now to see whether or not we get the debt ceiling increase. Otherwise, we don't have any money for anything.
Actually, from my perspective, along the years, I saw many Israeli companies that 5, 6, 10 years ago have come up with something that is doing the same, but in a more effective, cost-effective way. And in the past, it was not sexy for investors at all. It was not. You wanted to see the huge impact. You wanted to see the large market, and to a certain degree, these new rules provide an opportunity if you are making smart choices of where to go in terms of cost of development and for new products that may not have a breakthrough technology in terms of the actual technology. They are not measuring something which is completely new, but they do that like the flow metrics yesterday. that are doing it in a much cheaper way and much more convenient way for the patient, and can provide much more health information that allows the system to really reduce the cost
Exactly.
along the way. So the game now is different. You need to find these opportunities, which are maybe less sexy from a technological point of view, but can really address the needs of this market at this point.
No, I agree with that. I think that's exactly right.
The new state health insurance exchanges, they're simply an aggregator of possible insurance plans that citizens can come along and choose.
It depends. Every state, as usual, is different. So some of the states have private insurers bringing the plans to market. Other states have community plans. It depends on the state. But it is an aggregator in essence, because you're dealing with a bunch of individuals that are now seeking insurance as, a group in essence. But it's been, the number of hits on the websites have been incredible. And it's, last week there was a huge glitch. And when the system went live, and they had to shut it down last weekend to fix it. So it's not without its bumps in the road.
People don't have insurance, but at least they have internet. So
Everyone has internet.
And Susan said she'd get back to me to explain to us if Americans sitting here in Israel are entitled to the
You are, by the way. There's a delay in one of the reporting mechanisms that you have to engage in about opting out, but yes.
I'd like them to see what's going to happen with all the Americans around the world will suddenly now ask for U.S. insurance.
You pay for it. I mean, it's just easier to get. It's insurance. You pay for it. It's just easier to get. You can get a gold or a silver or bronze plan, but you're guaranteed basic minimum benefits, but you pay for it.
Yeah, when we go to the States, we can actually get insurance instead of
That's an opportunity
Shield.
for a new. Yeah, exactly. That's a new initiative.
When you
Joint
have
venture with that
when you have
insurance
a
for
pre-existing
Americans.
problem, going abroad becomes an issue. So now if you're an American going to the States, fine. But they pick up the bill if they want our taxes.
your problems.
No, it's not mine. It's all the Americans living abroad.
Well, any further questions?
We have to, I think as Hanan said, I think we have to digest some of this.
It's so easy.
Yeah, right.
If folks want, you'll have the presentation because you were kind enough to let us use your computer, but I'm happy to email this.
And we actually are going to probably post it on the IATI website and if possible on the Mintz Levin website, so we'll have it available there.
So you can hear it over and over and over again.
Until you understand what
So thank you very much.
Thank you.
Thanks a lot.
Yes.
You still have some?
Yes.
I ran out of mine.
Benny, thanks. It's great to see us always. My pleasure.
When is your next trip?
I don't know. Yeah, I'll have to talk about it. Hopefully soon. Yeah, when's my next trip?
probably in your environment.